Hey everyone, welcome to another edition of the Right Way Wednesday. Today I have Ruth Miller. Say hi, Ruth.
Hello.
With me from the Clinical Strategies Division at HealthPRO-Heritage, and we're going to talk about PDPM because it is coming fast. By the time you guys watch this, we will be, I guess, about a month away, so it's right around the corner. And so Ruth and I wanted to kind of talk about, I wanted to pick her brain a little bit about some last minute considerations around ICD-10 coding. You know, we've had ICD-10 coding, since 2015? ICD-10 has been around, so it's been a few years. But I don't know, I think any of us really could call us full-fledged experts here. We're still learning. There's so much that goes along with coding, and we know that clinicians are getting a little bit worried about this particular subject. I know our clinicians are asking lots of questions about it, so we thought we'd address some of those commonly asked questions today. All right, so Ruth, thanks for being with me. Really appreciate it. One of the things I think that our clinicians kind of ask a lot is, where do I look to get good ICD-10 diagnostic information to begin with? Like, where do I even start to look?
So the first place you'd want to look is to make sure you look at the hospital discharge summary and any other hospital documentation, but especially the hospital discharge summary. You'd also want to look at the medication list that the patient is currently on in case some of those codes have been missed. And the third area is you want to make sure to get the information from the admitting physician diagnosis, because the admitting physician notes will have the principal diagnosis or the primary reason that the patient is being admitted. And you'll need to validate that from the physician admission note into the skilled nursing facility.
Okay, I like the idea of going to that medication list because I don't think a lot of clinicians really think about that in regards to coding. They're looking at that maybe for side effects, but they don't really sort of sometimes connect that coding aspect. So that's a great tip. You know, you mentioned that discharge summary. I know we hear from a lot of clinicians out in the field, and I know I had a hard time with this too sometimes. Sometimes that doesn't come for a while. We don't get that right away. We talk a lot about having to code basically from day one now, right? Because we don't have a lot of time to get that done. So what are some suggestions for our clinicians if they're not getting that discharge summary quickly?
So we really have to start working as a team with our upstream partners, like the hospital. They have to understand why we need that information early on. Now more than ever, PDPM is definitely a collaborative approach, but it's collaborative amongst the different venues, from the hospital to the skilled nursing. We all have to know what's going on with the resident. So it's imperative that we educate our upstream partners so that we can receive that documentation in a more timely fashion.
Okay. All right. So let's talk a little bit about RTP codes, right? Because those are those return to provider codes. And we know that, or we've been saying that those are codes we do not want to use as a principal diagnosis. What happens if for some reason one of those codes gets on the claim as a principal diagnosis or on the MDS as one?
So that's a really good question, Nicole. So return to provider codes are codes that CMS has determined are not appropriate as the principal diagnosis or the primary reason for skilled nursing admission. So if we find that we have a return to provider code, first of all, we have to really identify and familiarize ourselves with the most commonly used one so we don't choose that. But if a return to provider code does get entered onto the MDS, it would be entered on that section I0020B. That would mean that that code would not classify to a PT, OT, or speech category, and a HIPS code would not be able to be determined, so we would not even be able to bill that claim. So you would have to go back and relook at the chart, investigate a little further, perhaps query the physician, and ask for a more definitive diagnosis.
Right. So it's really going to impact payment significantly, right? Because you're just not going to get any.
Correct.
You mentioned that a common return to provider code. At HealthPRO-Heritage, we do have a list that's available for reference. In addition to all of them, right? We do have some some documents that show all of them, but we also have a common RTP code list as well. And if you're not with HealthPRO-Heritage, I'm sure that your company has one too for you to reference as well. But you're going to find out as soon as that code goes into that section on the MDS for sure. But try to avoid that if possible. So let's talk a little bit about who determines that principal diagnosis, right? It's not the primary diagnosis anymore. We're calling it the principal diagnosis. Who's the one that actually determines which one that's going to be? How's that figured out?
So again, that's a collaborative effort that the IDT needs to discuss daily in the new clinical meeting or in your regular clinical meeting. What is the main reason that person, that resident, was admitted to your facility? That's the question that it has to answer. So we talk about it together as an IDT, but also the physician really does need to validate it on their admission note. And if it's not in the physician admission note, then we have to understand, why is this patient here? Does the physician support that? Because that's the first thing when auditors will review documentation, especially once it's tied to reimbursement. If the ICD-10 principal diagnosis is the reason the resident is admitted or the primary reason for the stay, we must be accurate and have supportive documentation for that.
Right, so a real team effort. Well, what about, we talked a little bit too, and we may have done this on a previous Right Way Wednesday, about active codes and diagnoses that have resolved, right? What about those types of codes? What do we use? What do we not?
So the REI manual is very clear about what an active code is. An active code, first of all, the diagnosis must be documented by a physician or physician extender within the last 60 days. But to determine if it's active, because that alone doesn't determine if a diagnosis is active. So to determine if a diagnosis is active, you have to look back at the REI manual. Clearly states a 7-day look back rule to see if this has affected the patient or will affect the patient's care plan in relation to their physical, cognitive, well-being, nursing monitoring, or risk of death within the last 7 days. So to go back to the interdisciplinary team, we have to make sure that we are talking about that and looking at the diagnosis to make sure that it has had a relationship or a direct effect onto that resident, as well as looking at the medication list. So when we spoke about medications earlier, sometimes physicians will leave some diagnoses, or it'll just be in a prior medical history, previous medical history. But if a patient is currently taking a medication, then it is considered for a disease, then that's considered an active diagnosis. And we would want to include that as part of our active diagnoses, not necessarily the principal diagnosis, but an active diagnosis. A resolved diagnosis is one that has no effect on that resident, cognitive, physical functioning, nursing monitoring, or risk of death or behavioral status within the last 7 days and does not drive the resident's care plan.
Right, and we want to think about that too, right? Because we always talk about coding multiple diagnoses and talking about those, but those that are relevant, and that means those that are actually impacting the plan of care, right? So you want to think about that critically. So
Has to be active.
I think the biggest question and the biggest, not necessarily fear, but worry or concern that rehab directors and clinicians, I think, are expressing right now is the time that it takes to figure out what codes they're supposed to be using, how to relate that back into their documentation, that whole process of, getting the right information, figuring out what the codes are, and then getting them onto our documentation and the MDS timely so that we can actually move forward, right? So, in your experience, how much time really should the process take if you have all of the systems put in place and your team communicating effectively? What do you think?
So that can take some time, but the biggest time is really reviewing the chart thoroughly and making sure that you look at the diagnoses, but also code the diagnoses accurately. So it's not enough just to see one diagnosis and then just determine, I'm just going to pick this diagnosis because it seems right and it has one word in it, like hemiplegia, but it might say undetermined side or unspecified,
right,
and result in a return to provider code. So you really have to invest time into reviewing the chart And so one idea is to outsource to a certified coder, hire a certified coder, or make sure that the people that are coding your charts are thoroughly educated in coding and have the time to review the charts. Another option that we've been working with is to offer an outsourced coding solution to facilities. And we've partnered with Imagine Solutions to offer outsourcing coding to a facility, because we understand the time and the burden that it is on whoever's doing the coding in the facility.
Right. So there are no shortcuts, unfortunately. You just have to review everything, right? Yeah.
We want to make sure that the codes are specific. We want to make sure that the codes are accurate and specific, because now that coding is tied to reimbursement, auditors will be reviewing your codes. Are they accurate? And is there supportive documentation to determine why that resident is there and to support what you are entering on that MDS?
Right. I think that's a really good point. Thanks for throwing that in. And that really goes across. We were talking a lot about PDPM, or obviously we're talking about PDPM today, but it really doesn't matter what payer we're talking about. We have to code accurately and specifically in order to support what we're doing. So good point. Any other words of wisdom before we sign off today, Ruth?
Is that we have to be very accurate and make sure that we have supportive documentation for whatever we're entering.
That's right. And so ask your questions here about documentation and coding. You can type it into the chat box below or shoot me a direct message, or you can ask the questions just by typing in and posting, and one of us will answer that for you. Thanks so much for watching. Thank you, Ruth, for being with me today. I really appreciate you taking the time out of your day to talk about this. Again, it's coming up and coming up fast, so get ready, be prepared, and let us know if you need any help. Happy documenting. Thanks so much. Bye.